I realized sometime in the 1990s or early noughties that there were assumptions underlying all our research on drugs and all our information and prescribing practice around psychiatric drugs. There were these underlying assumptions, and this main assumption was that they work by correcting some underlying abnormality, and an underlying biological abnormality that leads to the symptoms of a particular mental disorder. So antidepressants are thought to work on the biological processes that produce the symptoms of depression, for example. And it was when I started thinking about the nature of drugs and the sorts of altered states that they produce that I realized that there's this assumption, and that this assumption eclipses this other way of understanding what drugs do. And that's what I've called the drug-centered model. And the drug-centered model is the idea that drugs are drugs. They're substances that alter the normal state of the body. And psychiatric drugs are a special class of drugs that cross the blood-brain barrier. So they alter the normal state of the brain as well. And because they alter the normal state of the brain, they produce changes in people's feelings, thought processes, and sometimes their behavior as well. And we know that from other drugs that cross the blood-brain barrier, and we sometimes refer to as psychoactive drugs or mind-altering drugs, like alcohol, for example. We know that alcohol changes the normal state of the brain, and that has an impact on people's feelings and people's behavior. And so what I realized is that psychiatric drugs are no different. They change the normal state of the brain, and that has an impact on people's feelings and behavior that causes different feelings and different behaviors, which you can document in animals and in normal volunteers, so-called normal volunteers, people who don't have any history of or current psychiatric problems. And then what happens is that in someone who does have some mental health problems, anxiety, for example, or low mood, or more extreme things like psychotic symptoms, those changes that the drugs are producing are superimposed onto those underlying problems and difficulties, and obviously interact with them. So, for example, a lot of drugs reduce the intensity of emotions. One class of drugs that does that is the opiate drugs. They're well recognized to sort of produce this state of emotional indifference and disengagement. People who have had opiates for pain, for example, often say they've still got some pain left, but they don't care about it anymore. And that's this psychoactive effect, this change that they produce in our normal emotional responses. So a lot of other drugs numb emotions in different sorts of ways. And of course, if someone's feeling intense anxiety or intense sadness or intense distress of any sort, and they take a drug that numbs them, that is likely to lessen the intensity of those underlying emotions. So that's really what the drug-centered model is saying. And I suppose the importance of it is that if you accept that drugs have some sort of drug-centered action, then that calls into question the whole of the disease-centered model. If drugs are changing people's mental states because they're changing the normal state of the brain and changing normal feelings and behavior, then of course they're going to have effects on people who, have depression or anxiety or whatever else. And those effects may well explain the results of randomized controlled trials, the reported, the effects that people report when they say they feel better, or, that their feelings are less awful. And so there's really no need for the disease-centered explanation, it seems to me, or no need for it, but also no support for it, because there's this other possible explanation that's being ignored. So I think the drug-centered model should make us demand much better information about the effects of drugs on normal brain functioning before we start recommending drugs in the first place, and certainly before we start putting people on drugs for, you know, periods of months or years, as people often are. And I think it just also emphasizes, you know, we're putting a chemical into the body that is not, it's not rectifying something, it's changing the normal state of things. And therefore it is likely that there will be complications and adverse effects, and we need to be very careful when we do that, and we need to be absolutely sure that the benefits that people might get from a period of tranquilization or numbing or something like that, or, you know, help with sleep, are really worthwhile and outweigh the negative effects that probably come along with most long-term drug use.